Welcome. Good evening. Welcome to the e-poster session B. It's my pleasure to chair this session with Professor Stefano Centanni. We will have 9 posters to be discussed, and I want to start immediately because we have only 45 minutes, and the idea is to have a presentation of 3 to 4 minutes, and that having time for at least one question for each poster. The first one is presented by Ola Boyko from Dnipro, Ukraine, and the title is The Effect of Smoking on Nutritional Status and the Severity of a Disease in Patients with COPD. Please, the stage is yours.
Good evening, dear colleagues. My name is Olha Boyko, and I'm a PhD student from Dnipropetrovsk Medical Academy, Ukraine. The topic of my research is the effect of smoking on nutritional status and the severity of the disease in patients with COPD. Introduction. Chronic obstructive pulmonary disease is an urgent problem of modern pulmonology. Patients with more severe bronchial obstruction and body mass index less than 25 kilograms to square meter have a higher risk of death compared with patients with COPD who are overweight and even obesity. The aim of our research was to determine the effect of smoking on indicators of nutritional status in patients with COPD, materials and methods. A study included 95 patients with COPD. Patients were divided into 2 groups depending on the status of smoking, smokers and non-smokers. Criteria for inclusion in study were verified diagnosis of COPD in clinical groups B and C, stable phase. The exclusion criteria from the study were patients over 80 years old, history of acute cardiovascular events, clinically significant heart rhythm disturbances, previously diagnosed diabetes, kidney disease, cancer, surgical operation during last year. Everyone underwent an assessment of the severity of COPD, frequency of exacerbation during the last year, and assessing dyspnea using the MMRC scale, and a study of nutritional status. The percentages of total fat, muscle mass, and visceral fat were determined on the basis of bioimpedancemetry data with help of Omron analyzer. The program Statistica was used. Smokers had more severe dyspnea according to the MMRC scale. Also, in the group of smokers, more severe bronchial obstruction was observed. When studying nutritional status, it was found that smokers had an increase of fat tissue and a decrease muscle tissue compared to non-smokers with COPD. And also, the results were statistically significant. Conclusions. Patients suffering from COPD have a violation of nutritional status. Smoking patients develop sarcopenic obesity, which progresses with an increase in the degree of nicotine addiction, correlates with the pack-year index, and is a predictor of increased mortality in this category of patients. Increased bronchial obstruction in smokers with COPD is observed with an increase in smoking history, the number of cigarettes smoked, and with a decrease in body weight. Reducing the pool of muscle tissue can be considered as an early predictor of more frequent exacerbation in smoking patients with COPD. Thank you for your attention.
Thank you very much. I have a question. Did you correct the results for the personal performance of the COPD patient in terms of exercise? We know very well that the level of exercise correlates very well with the mortality or survival, if you want, and maybe the smokers have a lower level of performance and exercise. Do you have any data about this?
Yes, to my opinion and to opinion of my scientific supervisor, the patients with COPD have more severe dyspnea, and that's why these patients, of course, have a less level of life activity. Yes, and that's why maybe the level of life activity leads to the decrease in muscle tissue and of course increase in fat tissue. Yes.
Good. Yeah. Any question, Stefano?
Just a question. I didn't understand. Do you consider the smoker history by the number of pack years? Is correct?
Yeah. Yes.
But with a fixed cutoff, I mean, more than 20 pack years, or with the exact number of cigarettes smoking for each patient?
Unfortunately, yes. This is only the small part of a large research. And in this part of research, we divided the patients to smoker and not smoker. But in my research, I had results and information about the correlating relationship between the level of pack year index and the level of mass index and fat index. Yes.
Okay. Thank you.
Thank you.
So I think we can move to the second one.
Yes, it is COPD, alpha-1 antitrypsin serum concentration, and the airway obstruction, presented by Katerina Gashinova. Please. The microphone.
I'm sorry.
Okay.
Let's try again.
Yes. Perfect. Thank you.
Mm-hmm. Once again, it's a great pleasure and great honor for me to present my work. And it's well known that alpha-1 antitrypsin hereditary deficiency is a proved risk factor for COPD. However, we also know that only 1% of patients with COPD have a truly genetically determined AAT deficiency. That's why the aim of our study was to evaluate the serum AAT in patients with stable COPD without hereditary deficiency, and to study whether severity of airway obstruction depends on serum AAT concentration. We include into the study patients with confirmed diagnosis of COPD, all stages, and include patients with comorbid conditions like digestive system, malignancy, systemic connective tissue diseases, and with signs of acute inflammation. We evaluate the exacerbation history, smoking status, bronchodilator spirometry, and in accordance with the aim of our study, serum AAT concentration. Finally, we include into the study 45 patients with COPD. Most of them were men. And at the first sight, median AAT serum concentration were within normal ranges. However, in 9 patients, almost 20% of our patients, AAT concentration was low, and in addition, 13% had borderline AAT concentration. The difference in AAT was statistically significant in patients with different GOLD stages. And at the same time, FEV1 correlate with airway with AAT concentration. That allows us to conclude that 20% of patients with stable COPD have low serum alpha-1 antitrypsin concentration. At least in our region. And serum alpha-1 antitrypsin concentration negatively correlate with the severity of airflow limitation. Thank you for your attention.
Thank you very much and congratulations. Just a comment. I don't know how did you perform the functional test in your study population? But I strongly suggest to speaking about alpha-1 antitrypsin, and so involvement of lung parenchyma. I strongly suggest to consider also the volumes, not just the simple spirometry.
Okay. Okay, we do this, but we're not included into the study. But thank you for your advice. We will.
I think it's very important. It's very important.
Yeah. We also perform CT and evaluating the emphysema, of course. Thank you.
Okay.
We will include it.
Francesco, Professor Blasi.
It's fine for me. Thank you very much. And I will move to the third presentation. From Urania Koltsida from Greece, hypodiagnosis of primary antibody deficiency in patients with COPD, sarcoidosis, and chronic rhinosinusitis. Please.
Hello, for me. Can you hear me? Okay. Yes. Okay. I'm really sorry, but I was having trouble with my presentation. It's not in a PDF version. I'm really sorry, but I couldn't do something better because I'm on duty. I'm at the hospital. So my name is Rania Koltsida, and I'm going to present you our work on hypodiagnosis of primary antibody deficiencies in patients with COPD, sarcoidosis, and chronic rhinosinusitis. Sorry. How do I go? Our study was to investigate a possible PAD hypodiagnosis in patients with COPD, sarcoidosis, and chronic rhinosinusitis, because PAD represents the most common immunodeficiency in humans. And the major problem for these patients is that their diagnosis is delayed, and it leads to severe and irreversible complications. So a total of 284 patients were enrolled in the study. Here you can see the demographic data. Most of them were at the age of 40 to 60. And actually, 148 patients suffered from COPD, 35 from chronic rhinosinusitis, and 101 had an initial diagnosis of sarcoidosis. So we examined the levels of IgE, IgG, and IgA, IgM, IgG, and IgA. And then we proceed to more analysis. So out of 284 patients, 27 displayed IgG levels below the reference values. And after more subclass analysis, it was shown that finally 6 patients fulfilled the criteria for a PAD diagnosis. 3 of them had the common variable immunodeficiency, 1 for selective IgE deficiency and 1 for combined IgA and IgG4 deficiency, and 1 for combined IgG2 and IgG4 deficiency. And actually, I have to say that especially a 48-year-old male patient had a 5 history of COPD displaying bronchiectasis, and another 75-year-old female initially was diagnosed with sarcoidosis. She was under corticosteroid treatment, and she displayed undetectable Ig levels. And actually, our conclusions is that the early diagnosis of PAD is important for the clinical management and follow-up of patients, especially when chronic steroids treatment is needed. That could lead in severe complications, especially on the ground of immunodeficiency. And actually, early initiation of immunoglobulin replacement treatment can reduce the frequency of infections and prevent end organ damage in such patients. And we conclude that PAD hypodiagnosis is a common clinical problem, and awareness for early diagnosis should be encouraged. And prevalence of PAD in such patient cohorts is higher than the general population, thus than those clinical entires represent excellent targets for detection of misdiagnosed cases. So, okay, I think I'm finished.
Okay, thank you.
Thank you.
Thank you.
I think you put together three different diseases with clearly different outcomes and symptoms. When you looked at the two cases of sarcoidosis that are apparently without a good response in terms of immunoglobulin and the deficiency, both complete deficiency and partial deficiency, the diagnosis was made by which kind of testing? Sarcoidosis, because it's quite strange to have a sarcoidosis without any analysis of the immunoglobulin.
Yeah, the diagnosis in all these patients were made by biopsy. Especially, it was a ABAS-TBNA biopsy from lymph nodes. So it was a definite diagnosis of the sarcoidosis at the beginning.
Yeah, and then he suffered from a meningitis. I understand correctly?
Excuse me?
The patient had a meningitis.
Wait.
No. 75 years old had a meningitis. I understand correctly? Yeah.
No, it was diabetes mellitus and hypothyroidism. No.
Okay. Good. Okay, thank you very much.
Thank you very much. I'm sorry because I'm actually working at the hospital now. I'm on call.
Don't worry, we are all in our hospital, as you can see by that.
It's our job.
Soteria Hospital is the main, chest diseases hospital in Athens, and it's full of COVID patients.
Yeah.
Right now.
Generally speaking, doctors works in the hospital, so.
Nicoletta, Robina, we work in the same hospital, and we are both,
Yeah. Okay. Keep safe. That's the most important thing.
Thank you.
Stefano.
Yes. So the next poster is effect of erdostein administration on oxidative stress level and duration of exacerbation in asthma COPD overlap, presented by Dr. Olga Nesterovska. Please.
Good evening. So it's known that acute exacerbation is an important area in asthma and COPD, as it affects lung function and disease progression. So the objective of our study was to evaluate the effectiveness of erdostein administration as additional therapy in reducing oxidative stress level and duration of exacerbation in asthma COPD overlap patients. In our study, we included 30 patients and divided them into two groups, erdostein and control groups. Patient in erdostein groups number 15 received oral erdostein 300 milligrams twice daily and added to standard therapy during exacerbation period staying in a hospital. And we evaluate the level of systemic inflammation using fibrinogen and C-reactive protein level, and oxidative stress level using malondialdehyde level, serum total antioxidant capacity, and oxidative protein modification. So we evaluate duration of exacerbation, spirometry, 6-minute walk test, and asthma control and COPD assessment test questionnaire. All measurements were done at hospital admission after 10 days and after 3 months. Baseline demographic and baseline data were similar between erdosin and control group. You can see it on the slide. After hospital discharge, malondialdehyde concentration in erdosin group significantly decreased compared to control group, especially after 3 months. You can see it in this table. Serum antioxidant capacity 3 months after exacerbation increased more in erdosin group compared to control group, and mean exacerbation duration as well was lower in erdosin group compared to control group. The mean exacerbation actually was 9 days in erdosin group and about 13 days in control group. There was no difference in C-reactive protein level between groups, and no significant difference between when we evaluate asthma control questionnaire and COPD assessment test between these two groups. Fibrinogen level was lower in erdosin group after 10 days, but after 3 months there was no significant difference between groups. But what we see is that physical activity in patients being in erdosin group was better, especially after 3 months compared to control group, maybe due to the lower level of oxidative stress. So, and erdosin administration added to standard therapy during exacerbation period due to respiratory infection in patient with asthma COPD overlap can potentially accelerate recovery period, decrease level of oxidative stress, and therefore increase exercise capacity. Thank you for your attention.
Thank you very much. Very interesting. Oh, my question is, how did you perform the diagnosis of asthma COPD overlap?
It's an interesting question. So I started to select this patient a few years ago and perform some other kind of study with this group of patients. And at that time, there was famous Spanish criteria and Gold and GINA recommendation, as I remember correctly, 2015 years, 2007 criteria, and but now we a bit choose our criteria, and we based on Gold actually and GINA new guidelines, but in Ukraine, actually, we have patients with COPD and patients with asthma. And sometimes we have patients who used to have asthma from the childhood or from the adolescent, and maybe this patient kind of smoking and maybe work in such area. So sometimes they have not reversible
So you have asthmatic smoker patients?
I suppose that there are some asthmatic smokers in every country.
No, perfect. I agree.
And sometimes we have some patient. I'm here. I'm sorry.
No, it's okay.
Oh, it's okay because something wrong with my slide.
More light, maybe more light. You are in the dark.
Sorry.
You are in the dark, so perfect. Thank you.
Thank you. Sorry. And sometimes we have COPD patient with eosinophilic inflammation, and we are interested in eosinophilic inflammation as well, but maybe not just like one criteria for asthma COPD. So maybe it's better when a patient have a confirmed asthma and confirmed COPD. So we don't have a lot of this patient, but we have.
Okay, I agree. They are very rare patients, but it's fine for me. Thank you. Professor Blasi?
Yeah, hello.
Hey,
Tobias.
Welcome.
Ciao.
Ciao.
Sorry for being late. So up here, Toddy.
No problem. Now we are moving to Nepal. So, you know.
I'm here at the right time.
Yes, exactly. I think this mirror the international group that are present in this Congress. And from Nepal, we have Anusmriti Pal. And the presentation is outcome on non-invasive ventilation in patient of acute respiratory failure, hospital-based single-center study. I think it's a recorded one, but I see the presenter somewhere in the audience. So we can start with the presentation.
Hi, I'm Dr. Anusmriti Pal. I'm currently working as a pulmonologist and intensivist in Karnali Academy of Health Sciences. Today I'll be presenting on outcome of NIV in patients of acute respiratory failure, hospital-based single-center study. So let me start now. Acute respiratory failure is a condition in which respiratory system fails in both its gas exchange, that is oxygenation and elimination of carbon dioxide. NIV is a method of ventilated support, and it should be initiated early before severe acidosis occurs. And the NIV failure requiring invasive mechanical ventilation in decompensated patients is low, but in critical patients it can be as high as 60%. The purpose of my study was to assess the outcome of NIV, assess duration of its use, stay in ICU, and failure rate. It was an observational cross-sectional study conducted at Chitwan Medical College Teaching Hospital over the period of 6 months. Total 35 patients were enrolled, with median age being 73 years, among which 40% were males. Table 1 shows the diagnosis of patients who received NIV, among which 77.1% were COPD patients. Table 2 describes the overall days of ventilated support among NIV success group, with the median duration of NIV use was 17 hours, and maximum success group was COPD patients with 40%. NIV failure occurred in 54.3% of patients, with COPD being 48.1% and interstitial lung disease 50%. And the median duration of NIV used in this group was 10 hours. And these are the trends of years and PCO2 among NIV success and failure groups. In discussion, NIV efficacy depends on factors like patient selection, experienced medical team, selection of interface, and ventilator settings. And several comparative studies are shown here which have the similar findings as mine. On conclusion, use of NIV among ARF patients was associated with lower intubation and ICU mortality rate. COPD patients showed most benefit, and the median duration of NIV was used among success group was 17 hours, whereas in failure group it was 10 hours. These are some of the references. Thank you.
Very much. Is Dr. Pal with us?
Yes, I'm here.
Oh, good.
Hi.
Very
Good
welcome.
afternoon, everyone.
Very welcome from Nepal to to us. It's a very pleasure to have you with us.
Thank you. Thank you.
I think one of the main problems, you showed us the data on non-invasive ventilation in the ILD patient, where really most of these patients fail NIV
Yeah.
when the respiratory failure is there, because clearly COPD is a better patient for NIV. And you have about
Yes.
patient with interstitial lung disease. So you have such a high prevalence of ILD in Nepal, or is just the number of patients coming? You have a very high.
No, we do have a amount of patients of ILD, because nowadays, prior we used to think like the interstitial lung disease and the COPD patients are similar. We used to mix the diagnosis. We used to label all the patients of interstitial lung disease as COPD. Now, because of the investigations which are coming up in Nepal also, so we are able to diagnose the interstitial lung disease, and with the help of high resolution computed tomography scans of chest, it's been useful for us to diagnose interstitial lung disease better than prior.
So as a question.
Thank you very much for this nice presentation. What I am interested in, when the patients failed, what did you do? So are they mechanically ventilated, intubated and mechanically ventilated? And from those who failed, how many survived mechanical ventilation? Because the problem Francesco raised with interstitial lung disease is, yes, they fail non-invasive ventilation, but if you intubate them, they all also die. So interstitial lung disease patients are very hard to ventilate. It's a common problem.
Yes, thank you for the question. Most of the patients who were failed for the NIV in my study, most of them they were intubated, and some left against the medical advice, because in our country the people are mostly they are poor, so they cannot afford the mechanical ventilation charges and the hospital stay of ICU, so they left early against the medical advice. And the patients who were intubated, interstitial lung disease patients, they after 2 or 3 days also, most of the patients they left against the medical advice, or either they are died.
Okay, thank you very much.
It's a mixed results.
So I think we have to thank you for connecting from Nepal to. It's a very great pleasure to have you with us. And now I think it's time to move to the next one.
Yes, that is N-terminal Pro-B type.
Thank you. It's my pleasure too.
Okay, bye. Okay, so the next presentation is N-terminal Pro-B type natriuretic peptide predicts the severity of pulmonary hypertension in COPD. Presented by Gordana Pavliza.
Thank you. Good evening. Thank you for the opportunity to be with you this evening. Pulmonary hypertension is a common complication of COPD, and it also has an important implication on its prognosis. It carries the risk of more frequent hospitalization and shorter survival. But nevertheless, it's often overlooked due to difficulty in diagnosing. As we all know, echocardiographic assessment of PH may be subject of errors because of poor visualization of the heart due to emphysema, and right heart catheterization is an invasive method. So the aim of our study was to examine whether some routinely evaluated non-invasive parameters can predict which patient has pulmonary hypertension and which requires invasive diagnostic procedures. So we included 59 typical COPD patients, and they were all with confirmed pulmonary hypertension by right heart catheterization. We done complete blood count in all patients, NT-proBNP, troponin-T, arterial blood test, and pulmonary functional tests. So as you see, we included typical COPD patients and mean forced expiratory volume in per second over VFC was 54% of predicted. And PaO2 over VO2 level was 289. The parameters of right heart catheterization were as follows: mean right atrium pressure of 10.7 millimeters of mercury, mean PUP of 46.68, and wedge pressure of 12. Mean cardiac output was 5.34 liters per minute and mean cardiac index 2.8 liters per minute per square meter. So mild pulmonary hypertension was found in 70% of patients, moderate in 36%, and severe in 47%. And we found significant correlation between mPAP and NT-proBNP. P was 0.037. So in conclusion, NT-proBNP is released as a result of atrial and ventricular wall stretching, and it is known marker of left heart failure. But it is also elevated in conditions of right heart failure. It may indicate a load on the right heart. And there are a few studies on its value in identification of pulmonary hypertension in COPD, which indicate that NT-proBNP has relatively good sensitivity and specificity in identification of pulmonary hypertension in COPD. The results of our study are consistent with those mentioned above and suggest that NT-proBNP could predict the severity of pulmonary hypertension in COPD, but of course further research is needed to assess its value as a screening tool for non-invasive detection of pulmonary hypertension in COPD patients. Thank you for your attention.
Thank you very much. Some comments, Tobias, Francesco?
Yeah, I have a very sophisticated question. Thank you for presenting this data. So what is the controversy in most of the debates is it pulmonary hypertension due to COPD? Or is it a coincidence between diastolic left heart failure, HFpEF, heart failure with preserved ejection fraction, and pulmonary hypertension? Because we know from big observational studies that 40% of all COPD patients, and mainly the elderly, suffer from HFpEF. And it's, in my mind, it's more likely that it is left heart failure induced pulmonary hypertension and not COPD-related pulmonary hypertension.
You have to activate your microphone.
Excuse me. But wedge pressure was normal. So does that exclude the diastolic?
No, wedge pressure is normal in HFpEF. Therefore, it's preserved ejection fraction. So you need other echocardiography measurements like TEPC or right ventricular, left ventricular wall stress, or so on. But the wedge pressure is not helpful. It's always normal.
Okay, thank you for your comment.
Good, thank you very much.
Thanks.
So we can move to the e-poster number 7. Stefano Pini from University of Milan. Evolution of lung function, gas exchange, radiological patterns after discharge in patient with severe COVID-19 pneumonia, a monocenter observational prospective study. Please, Stefano.
Good evening, and thank you very much for the invitation. I'm Stefano Pini from the Division of Respiratory Diseases of Ospedale Sacco in Milan, and I will discuss the results of a study we conducted into our high dependency respiratory unit with the aid of our hospital's Division of Radiology during the first pandemic wave of COVID-19 in Italy. This was an observation and prospective study we conducted on adult patients hospitalized for COVID-19 pneumonia. At admission, we collected patients' anthropometrical and clinical data, as well as performing blood gas analysis and biochemistry. Then, after reaching respiratory stability during the hospitalization, we repeated blood gas analysis and we performed spirometry with assessment of lung diffusion capacity for carbon monoxide as well as performing a CT, a chest CT. Then we repeated such exams at 6 weeks after discharge. All CTs were then analyzed by 2 radiologists who assessed the total severity score, or TSS. As we can see in table 1, during hospitalization, most patients had a restrictive pulmonary pattern with a reduction of dynamic pulmonary volumes, as well as a reduction in lung diffusion capacity for carbon monoxide, and particularly a reduced alveolar volume. As regards gas exchange, most patients were mildly hypoxemic with an increased oxygen alveolar arterial gradient. As you can see in figure 2, during hospitalization, impaired gas exchange correlated with reduced lung diffusion capacity and reduced alveolar volume. At the follow-up, 6 weeks after discharge, we observed a normalization of dynamic pulmonary volumes in most patients, while a reduction in lung diffusion capacity persisted in most of them. We observed that D-dimer at admission correlated with a reduced lung diffusion capacity and reduced alveolar volume, both during hospitalization and at follow-up. This is an example of evolution of lung CT features from hospitalization to follow-up. During hospitalization, most patients had pulmonary consolidations, as well as granular opacities, mostly peripheral, and oral fibrosis. And the presence of consolidations correlated with decreased lung diffusion capacity. At follow-up, we observed that most consolidations had evolved into granular opacities or fibrosis. The total severity score was reduced, but not significantly so. We investigated for possible predictors of reduced lung diffusion capacity follow-up, and the only parameter that at our multiple regression analysis correlated was a predictor of reduced DLCO at follow-up was the D-dimer at admission. In conclusion, patients hospitalized with COVID-19 pneumonia show restrictive lung volumes and a reduction in lung diffusion capacity and alveolar volume. At follow-up, reduction in lung diffusion capacity can persist and is correlated with greater impairment of gas exchange during hospitalization and with higher levels of D-dimer at admission. In conclusion, we suggest that lung function should be assessed after discharge in patients hospitalized for COVID-19 in order to find out and eventually for monitoring possible functional alterations. Thank you very much for your attention.
Thank you. Any comments?
Yeah,
please.
I have a question and a comment. I did not get the point. What was the follow-up time? Was it 3 months or?
It was 6 weeks after discharge.
6 weeks.
6 weeks. Okay.
Yeah. And my question is, what do you think in RDS from for other reasons, influenza, whatever? Do you think it's different? Is it COVID specific or is it RDS specific?
Sorry, have you asked what is the difference between COVID-19 and other viral pneumonia?
I'm not sure. I think normally we do not look so close in follow-up to patients with viral pneumonia, and we have a control group with influenza pneumonia, and it's very, very similar. So it's not very different.
So the same behavior.
Yeah, maybe the difference is just, well, of course, the increased interest in the disease is due to the unprecedented number of patients which were hospitalized, and with the concern for possible outcomes was due to the very high number of very severe cases we observed, and from knowledge regarding the pathophysiology of the disease. For example, the involvement of alterations in blood clotting, and so the possible involvement of lung capillary bed.
Yeah, that's a very valid point. So there are some patients with a kind of chronic thromboembolic disease also in the late phase. And this is very important because I'm more in favor of diffusion capacity than of vital capacity. So if there is a constraining continuous diffusion capacity impairment, you should run a CT, but then it must be pulmonary vasculature focused, because this could be the main explanation for the findings.
I fully agree. Yeah. Thank you very much, Stefano.
Thank you very much.
Tobias, do you have influenza disease this year in Germany? Professor
up to today, so 15th of January, we had 38 cases, which is about 0.5%.
Okay. Yeah. In Italy too.
Of the normal influenza burden. Yeah.
Yes.
So influenza is on break this year.
Thanks to mask.
Yeah.
Something we have to have in mind in terms of prevention for exacerbation during the flu period when COVID is gone. Yeah. So maybe mask, like in Asia, is a very good preventive measure during this time.
Yeah.
Okay.
We have 8% of the COPD exacerbations in comparison to last year.
Yeah. Stefano, vuoi introdurre?
Yes. The next poster presentation is untuned antiviral immunity in COVID-19 revealed by temporal type 1, type 3, 1 interferon patterns and flu comparison, presented by Nicoletta Rovigna. Non posso parlare adesso, lo richiamo io più tardi. Grazie.
You have to open the microphone.
No, can you hear me now?
Yes.
Okay, thank you. I'm so sorry. Yes, of course. I'm so sorry for the inconvenience. Coronavirus disease triggered by the SARS-CoV-2 virus has become one of the worst pandemics of our time, causing high incidence of pneumonia and leading patients to the ICU. The hallmark of COVID-19 is the development of a hyperinflammatory response, also known as cytokine storm. And we and others have previously shown that beyond that inflammatory response in the viral pneumonias, a very central role is played by the interferons and specifically interferon lambda and interferon 1 as they orchestrate the antiviral immunity. So aim of this study was to investigate the immune response during the evolution of the disease and compare it with that seen in flu patients. So for that, we performed a temporal analysis of type 1 and type 3 interferons and major inflammatory cytokine patterns in 32 COVID-19 and 16 influenza A virus infected patients hospitalized for community-acquired pneumonia. And these patients were followed longitudinally up to their exit from the hospital, according to current WHO guidelines. Furthermore, we analyzed 24 milder flu patients with no radiological findings of pneumonia and no need for hospitalization, as well as 10 healthy individuals as control groups. So using high sensitivity Luminex and ELISA assays, we quantified 18 cytokines and chemokines relevant to antiviral immunity and hyperinflammation in patient sera collected at defined time intervals following hospital admission in the ward and in the ICU. So this aligned patients on the basis of the same clinical criteria of disease symptoms and severity, mainly the presence of pneumonia and the requirement for oxygen support. So here you may see the patient's characteristics. You can see in comparison the two groups, flu and COVID-19 patients, they have similar characteristics as for severity, markers and indices, but the difference is that COVID-19 patients in the ICU were lighter in severity. They had an Apache score of average 16 compared to flu patients that were in a more severe state, and they had higher inflammatory markers such as CRP and ferritin and lymphopenia. So what we found was that COVID-19 patients had profoundly impaired induction of both interferon lambda and interferon 1, although exhibiting temporally sustained high levels of inflammation, as you can see in comparison to flu. So interferons were very low throughout their entire hospitalization time in the ward and in the ICU. But in the flu patients, the interferons were produced normally. But in both groups, COVID-19 and flu patients, the inflammatory profile was expressed in a very high level and was sustained throughout 25 days of follow-up, as you can see. So in this slide, we show along severity the expression of inflammation and interferons. And you can see that non-critically ill COVID-19 patients don't produce interferons. They start producing after the day 7 to 10 some levels of interferons, while they overexpress inflammatory and pro-inflammatory cytokines. And this was not the issue in the flu patients, which produce normally from day 1 excess inflammation and excess interferons. And another interesting finding was that critically ill and non-critically ill patients had very distinct transcriptional signatures, and there were quite different clusters. Finally, we showed that these inflammatory and interferon profiles had a clinical interpretation. Patients with low interferon lambda levels had higher viral load in their respiratory tract. They had slower clearance of the viral, and they had a longer duration of hospitalization in the ward and in the ICU. And you can see that patients with flu, if deteriorating, they did very quickly, while patients with COVID-19 did that very slowly over a 7 to 10 day period. So in conclusion, this data point to an untuned antiviral response in COVID-19 patients contributing to persistent viral presence, hyperinflammation, and respiratory failure in contrast to flu. So the dysregulated antiviral response could explain one of the most notable features of SARS-CoV-2 infection, the fact that it goes unnoticed for a remarkably prolonged period of time, running a course of a mild or uncomplicated illness for days until sudden and severe symptoms develop in a subgroup of patients requiring hospitalization and some of them ICU support. Thank you very much for your attention.
Thank you very much for this nice presentation. Open to discuss. Professor Blasi?
Thank you very much. Very nice presentation. Interferon are clearly very important because if you look to, there is a trial ongoing on interferon beta for COVID-19. When do you think is the right time to start the treatment with interferons? Is the early phase of a disease, is the late phase, you have to treat the more severe, you have to treat the hospitalized patient, where you place the possibility to intervene with interferons?
That is a very interesting question, because I think that early in disease, we should start an interferon treatment early in the disease, not in the critical state. As we showed, the critically ill patients admitted in the ICU, mostly after 7 or 10 days in the ward, after being hospitalized in the ward, they just started to produce interferons after the 7th, 8th day. So they started to have, let's say, a defense system after 1 week of hospitalization. So I think someone might start with interferon treatment very early when the patient is admitted to the hospital, and then with other maybe with steroids to try and control the inflammation, which is sustained, and this sustained inflammation on the basis of the lack of a defense system finds the area and the way to produce detrimental effects to the organism. So I think interferons might be useful early in the disease, and that's my opinion. Of course, a lot of study has to be.
Yeah, it depends. You know, the interpretation may be different in terms of, you know, inflammation and so on. So the balance is not easy for sure. But I don't see the placement only in the early phase. I would say that, you know, maybe also in the inflammations response, it may be important to have interferons. But
it's a very difficult question, because if you use interferon, and we know it from sepsis trials, in the early phase you have reduced viral clearance. So maybe you have to combine interferon with antivirals, and this is the reason why the interferon part was so negative in the Solidarity trial. It could be that the systemic side effects are too big, and so a secondary trial is now started with inhaled interferon application. Maybe this is better. In the Solidarity trial, there was an inferiority of the interferon arm, so higher mortality than in the control arm. So
yeah,
if I'm allowed, sorry to interrupt, but if I'm allowed to make a small comment, I think it's interferon beta. Maybe we should look interferon lambda, which is maybe it's
maybe you are right.
Yeah, so I think more research is required in order to have definite answers on that. And of course, there are several phenotypes of patients. There is no uniform response in all of the patients. I mean, the critically ill patients are quite different than the patients in the ward with mild and moderate disease.
Yes, I fully agree. Good. Thank you very much.
Nice paper.
Thank you very much.
The presentation, we don't have the speaker. I'm correct? Okay, so we finish here, and I thanks very much all the speakers and the two chair that work with us for dealing with this session. And I asked to the two chairmen to wait a little bit. We will move to another room to decide the winner of the awards. So just a few minutes to decide. And I thank very much the speakers. Thank you very much.
Thank you for being here. So great pleasure.